The standard approach for non-squamous non-small cell, at least in 2017, involves a platinum combination in individuals who do not have an oncogenic driver. Usually that platinum combination is, in the United States at least, is carboplatin and pemetrexed. In individuals who are not candidates for pemetrexed, it's carboplatin plus a taxane either every 3 weeks or weekly. Up until very recently, in individuals who were candidates who did not have a history of hemoptysis or untreated brain metastases, I would generally graft bevacizumab onto the platinum combination. Again, either carbo and paclitaxel or carbo and pemetrexed. With the recent approval of pembrolizumab in this setting, specifically pembro in combination with pemetrexed and carboplatin, our therapeutic options have expanded, but they've also gotten a bit more confusing. The pembrolizumab was approved based on a randomized phase 2 trial that compared the combination of pembro with chemo to just chemo alone. Bevacizumab was not included in the control arm. So we have no direct head-to-head comparisons of pem-carbo bevacizumab versus pem-carbo pembrolizumab. And that is really the root of one of my dilemmas. There are some patients who have autoimmune disease or other contraindications to pembrolizumab where I will certainly preferentially use bevacizumab. The other interesting population are those with oncogenic drivers, be they EGFR mutations or ALK translocations. Here, immunotherapy does not work all that well. If you look at the randomized phase 3 trials in the second-line setting that compared single agents to docetaxel, the one group that consistently failed to derive any benefit were those with oncogenic drivers. The response rates were quite low. They were 3 or 4%. Survival advantages were not seen in that group. In fact, in some of these studies, there was a survival advantage for chemo. Ultimately, inevitably, those individuals will develop disease progression on the original TKI. And at that point, chemotherapy is the standard. And in my mind, chemotherapy, specifically a carbo combination with bevacizumab, is the standard for that population. I will much sooner use bevacizumab in those with oncogenic drivers once their disease has progressed on the initial TKI, ahead of using an immunotherapy, ahead of using pembro or nivo or atezolizumab. Whereas in a wild-type patient, particularly a patient with a high mutation burden, perhaps KRAS mutations, I will preferentially use immunotherapy in that setting.